Welcome, and first off, a huge congratulations on stepping into your new leadership role. Think of this briefing as your strategic guide to the latest, most critical updates in healthcare-associated infection prevention. Our job today is to take all that dense evidence from the 2022 compendium and turn it into actionable intelligence for you and your teams. So here's how we're going to tackle this. We'll start big picture with the global landscape, then zoom way in to understand our microbial adversary. After that, we'll walk through the new prevention playbook, talk about how to actually implement it using a great framework, cover how to measure your success, and then we'll take a quick peek at what's coming next. All right, first up, let's get our bearings. It's so important to understand the global context of our work. These numbers really drive how you're going to allocate resources and set realistic yet ambitious performance goals for your hospital. And right away, you see this pretty shocking disparity. In high-income nations like ours, we're benchmarking ourselves against a 7% prevalence rate. But you have to know that in much of the world, it's over 10%. So that's your strategic challenge right there, isn't it? How do you lead a top-tier program here while staying mindful of the global fight and the resource gaps that exist elsewhere? To really win this fight, you have to understand your enemy. And the enemy's number one weapon, the reason our device-associated infections can be so darn persistent, is its ability to build this incredible fortress we call a biofilm. The most important thing to get here is that we have to stop thinking about bacteria as just single, free-floating organisms. A biofilm isn't just a pile of germs. No, it's a sophisticated, fortified city. It's highly organized, it's protected, and it is built for the long haul, right on the surfaces of things like catheters and ET tubes. This whole life cycle explains so much of what we see at the bedside. It all starts with attachment. You have pathogens like S. aureus that use these specialized tools, these fibronectin binding proteins, to grab on and get a foothold. Then they enter maturation, where they build that slimy protective shield. And finally, you get dispersion, where the city sends out colonists, seeding the bloodstream and causing those really frustrating recurrent infections that seem to come out of nowhere. And this just perfectly illustrates the problem we're up against. Our best weapons, powerful antibiotics, even the patient's own immune system, they often just bounce right off. That gooey EPS matrix physically blocks the drugs from getting in. And then, deep inside the biofilm, you had these persister cells that go into a deep sleep, becoming basically invisible to any drugs that only target actively growing bacteria. It's a brilliant defense. Okay, so now that we know what we're fighting, let's get to our new playbook. The 2022 compendium updates are designed to directly counter these microbial strategies. And let's be clear, these are not just suggestions. They are evidence-based mandates for safer patient care. This is a massive change in how we track ventilator-associated events. We're getting away from relying only on those more subjective signs, like watching for changes in PEEP and FiO2. The new standard is much stricter, much more objective. To officially classify an event as an infection-related complication, you now must have microbiological proof. No wiggle room. And here is another absolute game changer, especially for your ICUs. The old way, just doing a routine CHG rinse for everyone, that's no longer the blanket recommendation. The evidence now points overwhelmingly to mechanical disruption. And why is that? Because dental plaque is a perfect biofilm reservoir. A chemical rinse can't break it up, but toothbrushing physically destroys it. This is a critical pivot in practice. When it comes to SLABC, our focus on what happens after insertion is sharper than ever. Think of these three practices as completely non-negotiable. Number one, the most important question you can ask every single day. Does this patient still need this line? If the answer is no, it has to come out. And for the lines that stay in, meticulous scrub the hub and mandatory CHG dressings are the law of the land. The updates for CAUTI and surgical site infections are just as targeted. For CAUTI, the single best thing we can do is get the catheter out sooner. That means empowering your nurses with protocols so they can make that call. And for SSIs, we're seeing more and more procedure-specific mandates. A perfect example is the new essential requirement for preoperative vaginal prep for every single hysterectomy. So knowing all these updates is great, but it's only step one. Your job as a leader is to actually make it happen. And thankfully, the compendium gives us a really simple but powerful framework to do just that, the 4 E's. This right here is your operational roadmap. First, you engage. You get your frontline staff and your leadership to buy in. Then you educate, and not just with an email, but with real hands-on training. Third, you execute by standardizing everything with checklists and kits to make the right thing the easy thing to do. And finally, you evaluate. You measure everything with hard data, and you feed that information right back to your teams. Let's make this super practical. How do you execute that new SSI guideline? Well, you don't just send a memo. You build it into the workflow. You work with sterile processing to create standardized prep kits. You get IT to update the surgical checklist and the EHR so it's a required field. And you build in real-time checks by auditing it during the pre-op timeout. See? That's how you hardwire a new practice. Now for that last E, evaluate. As a director, your data is everything. But here's the catch. If you're not interpreting it correctly, you could end up sending your teams chasing problems that aren't even real. So the next time you're looking at your CLABSI report, I want you to ask yourself this question. Because the truth is, not every bloodstream infection in a patient who has a central line is actually a CLABSI. And this is exactly why understanding MBI-ELKBI is so incredibly important for you. In your severely immunocompromised patients, their own gut bacteria can actually leak across the mucosal barrier and get into their blood. This is a known complication of their underlying disease and its treatment, not a failure of catheter care. And the NHSN gives us specific criteria to identify these cases. Following these 3 steps is absolutely essential for accurate evaluation. You have to apply the NHSN definition to filter out these MBI events before you even start your analysis. This way, you're measuring true prevention failures, and you're giving your leadership, and more importantly, your frontline teams, a fair and accurate picture of their real performance. Okay, as we start to wrap up, let's just take a quick look over the horizon. Because while bundle compliance is our day-to-day reality, the future of infection prevention is already exploring some really fascinating new strategies. One of the coolest ideas out there is something called quorum quenching. Think about it. Instead of just trying to kill bacteria with antibiotics, which we know drives resistance, what if we could just jam their communication signals? If we can disrupt how they talk to each other, we can stop them from forming biofilms or activating their attack mode in the first place. It's a strategy of disarmament, not just brute force, and it could be a huge weapon against antimicrobial resistance down the road. And really, this is the ultimate question for you in your new role. Your job isn't just about reacting to infections after they happen. It's about building an entire culture of proactive prevention. It's about taking the knowledge we've talked about today and embedding it so deeply into the fabric of your organization that patient safety becomes the default, automatic choice. Thank you.